All right, welcome to your high-yield D-Arcade revision on hemorrhoids. Look, if you're prepping for exams or you just want to really nail this super common clinical challenge, you are in exactly the right place. Let's jump right in.
So what exactly are we dealing with here? At its very core, hemorrhoidal disease is basically a plumbing problem. Seriously, think of them like varicose veins, just in the anal canal. They pop up when there's too much pressure, causing the veins down there to swell up and the tissues holding them in place to get weak. And that's really the long and short of it.
Now, the very first, and I mean the most critical question you have to ask yourself is this. Are we dealing with internal or external hemorrhoids? This one distinction, it's like a fork in the road. It's going to determine everything that comes next, from the patient's symptoms all the way to how we manage it.
And this slide lays it out perfectly. It all comes down to one key landmark, the dentate line. Anything above that line, you've got internal hemorrhoids. Now that area has visceral innervation, which is just a fancy way of saying it can't feel sharp pain. And that's why they usually show up with painless bright red bleeding. But below the line, that's external hemorrhoid territory. It's covered by skin with tons of nerves that feel everything. That's why they hurt, especially if a clot forms inside, which we call a thrombosis. So remember this. Painless bleeding points to internal. Painful swelling points to external. Got it?
Okay, so we know what they are, but why do people get them in the first place? And how do we figure out how bad they are? Well, that brings us right to risk factors and grading.
You know, when you look at this list, there's one theme that connects almost all of them. Increased intra-abdominal pressure. Straining on the toilet from constipation, the weight from a pregnancy, even just sitting for too long. It all pushes down on those veins, causing them to bulge. And a low-fiber diet is a huge contributor because it directly leads to the kind of hard stools that make you strain.
And here is a super critical point, especially for your exams. The grading system we're about to talk about applies only to internal hemorrhoids. Let me say that again, only internal. You absolutely cannot pick the right treatment without grading them first. It's a non-negotiable step.
You can see a really clear progression here, right? It's all about prolapse, whether or not they're sticking out. Grade I, they just bleed. No big deal. Grade 2, they prolapse when you strain, but they pop back in on their own. By grade 3, they're out, and the patient actually has to push them back in. And grade 4 is the end stage. They're permanently prolapsed and you can't reduce them. Knowing this staging is absolutely key to planning treatment.
Excellent. We know what they are, we know how to classify them. Now let's get practical. Let's walk through what you actually do when a patient shows up with these symptoms.
The good news is the workflow is pretty straightforward. You start with a simple inspection. Just look. You might see an external one right away or a prolapsed internal one. Next up, a digital rectal exam, a DRE, to feel for anything unusual. And finally, you'll use a proctoscope or an anoscope to get your eyes directly on the anal canal and confirm if there are internal hemorrhoids.
And this is the million-dollar question, isn't it? Rectal bleeding is super common, but it can also be a sign of something way, way more sinister. So how do you know when you need to dig deeper?
Okay, here are your hard and fast rules. You have to burn these into your brain. Any patient over 40 years old with new rectal bleeding gets a colonoscopy to rule out colorectal cancer. Period. No exceptions. And for a patient of any age, if they have red flag symptoms, like they're losing weight without trying or they're anemic, they need a colonoscopy. The number one rule is to never just assume it's hemorrhoids without ruling out the scary stuff.
All right, let's switch gears and talk treatment. The way we approach this is like a ladder. We always start on the very bottom rung, and we only climb up if we absolutely have to.
For the huge majority of patients, especially those with grade 1 or 2 hemorrhoids, we begin with simple, conservative measures. This is the foundation for everything we do.
And really, this is all about tackling the root cause of the problem. We tell them you've got to get more fiber in your diet, drink plenty of water. That's going to make stools softer and easier to pass. Stool softeners can help too. We counsel them to stop straining and to not sit on the toilet scrolling on their phone for half an hour. And for some immediate relief, warm sitz baths and topical creams can feel really, really good.
Okay, but what if all that's not enough? If the symptoms are sticking around, we climb to the next rung on our ladder. Minimally invasive procedures that we can do right there in the clinic. The real workhorse of office procedures is something called rubber band ligation. It works great for grade I through 3 internal hemorrhoids. It's simple, really. A tiny rubber band is placed at the base of the hemorrhoid, which cuts off its blood supply. Eventually, it just shrivels up and falls off. Sclerotherapy and coagulation are just other ways of getting to the same result. So for the folks who don't get better with those office procedures, or for patients with really severe disease, we're talking grade 4 internal hemorrhoids or an acutely thrombosed external one, well, that's when we have to bring out the big guns, surgery.
A formal hemorrhoidectomy, where the hemorrhoid tissue is surgically cut out, is hands down the most effective treatment for severe grade 3 and 4 disease. But it does have the longest recovery time. Now, for that patient with an incredibly painful thrombosed external hemorrhoid, the go-to is a simple thrombectomy. You make a small incision, get that clot out, and boom, the relief is immediate and dramatic.
Okay, let's wrap this up with a rapid-fire review. If you're cramming for an exam and remember nothing else, please remember these next few points. They're absolute gold.
This is your #1 clinical pearl. You see bright red blood on the toilet paper. Patient says it doesn't hurt. Your first thought has to be internal hemorrhoids.
And here's the other side of that coin. A patient comes in complaining about a tender, really painful lump right around the anus. Ding, ding, ding. You're thinking of a thrombosed external hemorrhoid.
And this one? This might be the most important takeaway of all. Rectal bleeding is cancer until you prove it's not, especially in patients over 40 or anyone with red flags. You cannot afford to miss this.
And this just pulls our entire management strategy together. Your approach has to be logical and stepwise. First, you grade the internal hemorrhoid. Second, you always start with the simplest, least invasive options first.
So, let's put it all to the test with one last quick scenario. A patient rushes in with sudden, severe pain and swelling right at the anus. What's jumping to the top of your differential diagnosis? I'll give you a second. Yep, if you were thinking thrombosed external hemorrhoid, you absolutely nailed it. And that's your high-yield review of hemorrhoids. Master these concepts and you'll be set. Thanks for joining me.